This recording will go over hiatal hernias. Hiatal hernias involve the protrusion of the stomach through the esophageal hiatus of the diaphragm into the chest. The esophageal hiatus is the opening in the diaphragm through which the esophagus passes from the thorax to the abdomen. Most patients with hiatal hernias are asymptomatic, but some may have daily symptoms similar to those with GERD. The two most common types of hiatal hernias are sliding hernias, which are the most common, and paraesophageal or rolling hernias. The esophagogastric junction and a portion of the fundus of the stomach slide upward through the esophageal hiatus into the chest, usually as a result of weakening of the diaphragm. The hernia generally moves freely and slides into and out of the chest during changes in position or intra-abdominal pressure. Although volvulus or twisting of the GI structure and obstruction do occur rarely, the major concern for a sliding hernia is the development of esophageal reflux and associated complications. The development of reflux is related to chronic exposure of the lower esophageal sphincter to the low pressure of the thorax, which significantly reduces the effectiveness of the lower esophageal sphincter. With rolling hernias, the gastroesophageal junction remains in its normal intra-abdominal location, but the fundus, and possibly portion of the stomach's greater curvature, rolls through the esophageal hiatus and into the chest beside the esophagus. Reflux is not usually present because the lower esophageal sphincter remains anchored below the diaphragm. However, the risk for volvulus or twisting of the structure, obstruction, and strangulation are high. The development of iron deficiency anemia is common because slow bleeding from venous obstruction causes the gastric mucosa to become engorged and ooze. The primary symptoms of sliding hiatal hernias are associated with reflux. Auscultate the lungs because pulmonary symptoms similar to those of asthma may be triggered by episodes of aspiration, particularly at night. A detailed history is crucial in attempting to differentiate angina from non-cardiac chest pain caused by reflux. Symptoms resulting from hiatal hernia typically worsen after a meal or when the patient is in the supine position. In those with rolling hernias, assess for symptoms related to stretching or displacement of thoracic contents by the hernia. Patients may report a feeling of fullness after eating or have breathlessness or a feeling of suffocation if the hernia interferes with breathing. Some may experience chest pain associated with reflux that mimic angina. Please review Chart 54-4, Key Features of the Sliding and Rolling Hiatal Hernias. The barium swallow study with fluoroscopy is the most specific diagnostic test for identifying hiatal hernias. Rolling hernias are usually clearly visible, and sliding hernias can often be observed when the patient moves through a series of positions that increases intra-abdominal pressure. To visualize sliding hernias, an EGD may be performed to view both the esophagus and gastric lining. Patients with hiatal hernias may be managed either medically or surgically. Sliding hiatal hernias are most commonly treated medically. Large rolling hernias can become strangulated or obstructed, therefore early surgical repair is preferred. The collaborative interventions for patients with hiatal hernia are similar to those for GERD and include drug therapy, nutrition therapy, and lifestyle changes. The primary healthcare provider typically recommends antacids and a proton pump inhibitor such as lansoprazole, omeprazole, or esomeprazole in an attempt to control reflux and its symptoms. Nutrition therapy is also important and follows the guidelines discussed for GERD. Several types of hiatal hernia repair procedures are used, each of which involves reinforcement of the lower esophageal sphincter by fundoplication. The surgeon wraps a portion of the stomach fundus around the distal esophagus to anchor it and reinforce the lower esophageal sphincter. For the transthoracic surgical approach, teach the patient about chest tubes. Inform him or her that an NG tube will be inserted during surgery and will remain in place for several days. Oral intake is started gradually with clear liquids after peristalsis is reestablished or to stimulate peristalsis. Instruct the patient on how to deep breathe and use the incentive spirometer. In paraesophageal repair, several half-inch incisions are made in the abdomen through which the hernia is closed and typically reinforced using mesh. In terms of post-op care, patients having the LNF procedure or paraesophageal repair via laparoscope are at increased risk for bleeding and infection, although these problems are not common. The nursing care priority is to observe for these complications and provide health teaching as described in Chart 54-5. Please review Chart 54-5 as well as 54-6 on your own. Post-op care after conventional open repair closely follows that required after any esophageal surgery. Complications after open surgery are more common and potentially serious. The primary focus of care after conventional surgery for hiatal hernia repair is the prevention of respiratory complications. Elevate the patient's head of the bed at least 30 degrees to lower the diaphragm and promote lung expansion. Assist the patient out of bed and begin ambulation as soon as possible. Be sure to support the incision during coughing to reduce pain and prevent excessive strain on the suture line, especially with obese patients. Incentive spirometry and deep breathing are routinely used after surgery to maintain patency of the airways and lung expansion. Adequate pain control with analgesics is essential for post-op deep breathing and coughing. The patient having the conventional surgery usually has a large bore NG tube to prevent the fundoplication wrap from becoming too tight around the esophagus. Initially, the NG drainage should be dark brown with old blood. The drainage should become normal yellowish green within the first 8 hours after surgery. Check the NG tube every 48 hours for proper placement in the stomach. It should be properly anchored so it does not displace, because reinsertion could perforate the fundoplication. Follow the surgeon's directions for care of the patient with an NG tube. Monitor the patency of the NG tube to keep the stomach decompressed. This prevents retching or vomiting, which can strain or rupture the stomach sutures. The NG tube is irrigated. Irritating. The NG tube is irritating. Therefore, provide frequent oral hygiene to increase comfort. Assess the patient's hydration status regularly, including accurate measures of INOs. Adequate fluid replacement helps thin respiratory secretions. After open fundoplication, the patient may begin clear fluids when peristalsis is reestablished or in an effort to stimulate peristalsis. Some surgeons create temporary gastrostomy for feeding to allow for undisturbed healing of the repair. The patient gradually progresses to a near normal diet during the first 4 to 6 weeks. Some foods, especially caffeinated or carbonated beverages and alcohol, are either restricted or eliminated. The food storage area of the stomach is reduced by the surgery, and meals need to be smaller and more frequent. Carefully supervise the first oral feeding because temporary dysphagia is common. Continuous dysphagia usually indicates that the fundoplication is too tight and dilation may be required. Another common complication of this surgery is gas bloat syndrome, in which the patient is unable to voluntarily eructate or belch. The syndrome is usually temporary but may persist even in those who have had the laparoscopic procedure. Teach the patient to avoid drinking carbonated beverages and eating gas-producing foods, especially high-fat foods, chewing gum, and drinking with a straw. Other patients have aerophagia or air swallowing from attempting to reverse or clear acid reflux. Teach them to relax consciously before and after meals, to eat and drink slowly, and to chew all food thoroughly. Air in the stomach that cannot be removed by belching can be extremely uncomfortable. Please review the care coordination and transition management section on your own.